Hello, my name is Hannah Boyinger, and I chose to do my research project for my microbe on Listeria monocytogenes, particularly because I'm 6 months pregnant, and I thought it would be interesting to look closer at its impact on pregnancy as well as other vulnerable groups. So what is Listeria monocytogenes? So, in microbiology and in the clinical prevalence of Listeria in 1940, Puree formally introduced the genus Listeria for this group of gram-positive, catalase-positive rods with non-spore-forming bacteria. The recognition of its pathogenic role began in 1949 after an outbreak of neonatal listeriosis in Germany. J. Patel isolated this bacteria from affected newborns, though initially misclassified them as Coronium bacterium. H.P.R. Seeliger correctly identified the organism's motility and reclassified it as Listeria, launching modern listeriosis research. Seeliger later authored the foundational book of listeriosis and led international collaboration on listeria studies. And so the characteristics of Listeria are noted here, that they have facultative, anaerobic, catalase positive, and oxidase negative characteristics as a bacteria. They move with a tumbling motility of 20 to 25 degrees Celsius due to its periticious flagella. They can survive and multiply in refrigeration under harsh food processing conditions, and they form biofilms on equipment and surfaces, contributing to persistent contamination. They're commonly found in soil, water, animals, and food production environments. So the disease overview of listeriosis, its transmission, and then who's at risk in our population. So transmission occurs when Listeria monocytogenes causes listeriosis when contaminated food is consumed. These specific foods are noted here: raw or unpasteurized milk and dairy products, queso fresco and other soft cheeses, raw or processed fruits and vegetables, undercooked meats, especially poultry, hot dogs, deli meats, and seafood and raw pet food. So at-risk populations, particularly pregnant women and newborns. Pregnancy alters the immune system, and so this increases susceptibility. Older adults and immune-compromised individuals. This includes adults 65 plus and individuals with weakened immune systems. For example, cancer, HIV, AIDS, diabetes, and then those with organ transplants. And these people are less able to fight infection. Just kind of a little diagram here talking about populations that are at risk, and briefly I'll just kind of note as it relates to me at least, or I'm focusing on pregnancy, but these are all of the at-risk populations kind of noted here, and this is instances in every 100,000 individuals per year in the United States. For pregnant women, it is 12 in every 100,000 women that contract listeriosis. So taking a closer look at the life cycle and the disease progression, this begins after ingestion of contaminated food, those foods that we were talking about earlier. Bacteria then colonize in the digestive tract and cross the intestinal barrier. From there, they spread to the mesenteric lymph nodes, then they enter the bloodstream. The primary target organs are the liver and the spleen, and this is where the bacteria may persist. This can lead to septicemia, meningitis, or encephalitis. And in pregnancy, the bacteria can cross the placental barrier, which we'll talk about a little bit more in just a second. The intercellular life cycle of this bacteria, they start by entering into the cells via Zephyr mechanism involving INLA and INLB proteins. They escape from the vacuole using listeriosin O, LLO, and PI, PLC. They replicate freely in the host cell cytoplasm. They use actin A protein to hijack the actin, and this creates comet tails for movement. They spread directly between cells, avoiding immune detection. And they also escape the double membrane vacuoles using LLO and PC-PLC. So taking a closer look at the impact of Listeria on pregnancy and newborns is that pregnant women are 12 times more likely to contract listeriosis compared to the general population. Infection may cause mild flu-like symptoms in the mother, and then sometimes the mother might not notice any symptoms at all. Placental invasion and fetal infection mechanisms. The cell-to-cell spread from infected maternal phagocytes is key to transplacental infection. Placental immune tolerance creates a safe zone for Listeria to thrive undetected. Cytotrophoblasts at the maternal-fetal interface are primary targets. The INLP protein may help the bacteria to colonize the placenta specifically. Some strains of Listeria show higher virulence and are more likely to cause maternal-fetal infections. So here's another slide of the impact of Listeria on pregnancy and newborns. So after the Listeria crosses the placental barrier, it can cause placentitis. And in this diagram, it kind of shows the process of how all of that takes place. And this can lead to some pretty serious consequences, including miscarriage, especially in early pregnancy, stillbirth, preterm birth, and neonatal sepsis or meningitis. Continuing to look at the Listeria impact on pregnancy and newborns, specifically early versus late pregnancy observations, shows that early infections may cause rapid fetal loss within 7 to 13 days post-infection. Late pregnancy infections often show delayed fetal impact around 47 days. The risk may increase in multifetal pregnancies and late gestation due to higher uterine blood flow and immune tolerance. Congenital or in utero infections of the fetus cases often carry a very poor prognosis, which include life-threatening infections to the newborn shortly after birth, permanent complications such as brain damage, developmental delays, or other severe health issues, as well as lower chances of full recovery despite treatment. Late onset listeriosis can occur after birth, during delivery, or via the hospital exposure, but this is usually generally considered less severe. Diagnosis for Listeria monocytogenes is crucial, and when you are gathering a specimen, it has to be from either the blood, the cerebral spinal fluid, or the placental fluid in pregnancy cases. It is then cultured on a Muller-Hinton auger. The gram stain shows gram-positive rods. The colonies are beta hemolytic. They break down red blood cells. Stool cultures are not usually a reliable source as they are low in sensitivity and specificity, but early detection is critical, especially in high-risk populations, pregnant women, elderly, and immune-compromised. So treatment and management of listeriosis includes assessing a hemodynamic status and stabilizing the patient. If meningitis is suspected, performing blood cultures, lumbar spine punctures, CT scan, and starting empirical antibiotics. Antibiotic therapy includes first-line IV ampicillin or penicillin G, and then an alternative to a penicillin allergy would be trimethoprim sulfamethoxazole. Listeria is naturally resistant to cephalosporins. Your case-by-case basis for meningitis treatment by population. Infants under 1 month old, ampicillin and gentamicin would be recommended. Older adults or immune compromised would normally be given vancomycin, ceftriaxone, or ampicillin. Future directions, as well as concluding my microbe research project on Listeria monocytogenes and its impact on our populations, particularly pregnancy, is that it poses a serious health risk during pregnancy due to immune suppression and its ability to invade the placenta. Even mild or no symptoms in the mother, infection can result in miscarriage, stillbirth, and neonatal listeriosis. So prevention through food safety is especially important and is the key to reducing maternal and fetal risk. And prevention methods, obviously avoiding the at-risk foods that we talked about earlier, for example, deli meats, the soft cheeses, seafoods, unpasteurized milks, and stuff like that. But you can also use, particularly for deli meats, you can use a FDA-approved bacteriophage P100 spray to treat deli, or you can cook it up to 165 degrees Fahrenheit. Looking ahead for future research, we should focus on faster, more accessible diagnostic tools for early detection, expanding public health education on listeriosis and its risks, and food handling, and better monitoring and regulation of high-risk foods. Here is my reference slide. And that concludes my micro presentation. Thanks for listening.